Hi, my name is Mary. We're back here with Angelo and Dwayne. So we talked earlier about the systemic barriers, right? And we talked about the problem. We laid the groundwork with the problem. In this segment, I want to really focus in on what are some solutions and what are some things that we can do both as researchers, as providers, as a community. What are some of the things that we can do? So in understanding 1 in 2 Black MSM will get an HIV diagnosis within their lifetime. This is new information released here at CROI from the CDC, and 1 in 4 Latino MSM as well. Dwayne, earlier you were talking about PrEP, pre-exposure prophylaxis, Truvada, which is used as an HIV prevention medication, a once-a-day pill. So I want to lay the ground and open the conversation with asking, in a perfect world, what would make accessing PrEP for marginalized communities easier? How do we break down those barriers, and what would that look like?
So, okay, I want to try to say as much as I can in as short amount of time as possible, because this is like a topic that we could spend hours on.
Yeah, that's true. Yeah.
But so at Fenway Health, actually, we have about 1,300 MSM who are on PrEP, who have initiated PrEP, and that's a lot of people. I think less like a year and a half ago, we were at 100. So it's like been a very quick upswing of people on PrEP. But we only have, of those, only about 100 are Black MSM who are on PrEP. And so that's a clear disparity. There's a clear reason. It's not just happenstance, right? And so when we look at those types of numbers, we have to think strategically about why those numbers exist and how we can change them. And I've always said, in this kind of new age of HIV, we really have to start looking at how we do kind of case management for HIV positive people and figure out a way to duplicate that for HIV negative folks. We have a great, Ryan White funding system that focuses on making sure that HIV positive people get their meds, housing, lots of different services.
Yes. Yeah.
But we don't really, if you're HIV negative,
there's no care continuum.
Right, there's no, exactly, there's no care, perfect. There's no care continuum for HIV negatives. And if we're gonna have PrEP, and the research is showing, we're gonna continue to have different types of pre-exposure prophylaxis that are gonna come out. It's not gonna just be a pill. 5 years from now, it may be a different pill. It may not just be Truvada. It may be an injectable. You may be able to do PrEP at home. There's different types of research out there that are going to come. There's going to be a lot more in the toolbox, a lot more options. So if we're going to have all these options, we need to have more of a succinct, more strategic way of making sure people are accessing them.
Yeah. Something that you said that really stood out to me, and this is something that I've been talking a lot about, the need for a care continuum for people who are negative. Specifically, people who are high-risk negatives, right? Who live in certain populations at highest risk for HIV, who come from certain backgrounds, to certain age groups, with certain backgrounds. These people have to have a certain continuum in intense case management, right? Because they also come with a host of other issues.
Right.
Housing, underemployment, a host of different things. And I think that before we can start to talk about, prevention for HIV and condoms and lube and all that stuff, we have to start to look at what are the things creating the barriers for them to even get into a doctor, to be able to see a doctor every 3 months, to get regular blood work, to get to a pharmacy, or to get their medication. We have to talk about what are those barriers for them. And I think that is, for me, one of the major things that we're working on here in Boston, and looking at how can we work with high-risk negative populations to ensure that the issues that are preventing them from receiving prevention period, how are those things being addressed?
Yeah, definitely.
What comes to mind is just the fact that we don't take into consideration how important it is to have parents, how important it is to grow up in an environment where you're sitting around the dinner table having conversations about when you're going to college and you're 11 years old, right?
Yeah.
To you, it makes no sense, but mom and dad are already thinking of those things. Coming from a background of people who understand the way the healthcare system does, right? And I think for us, once again, as communities of color, we don't have that. The healthcare system was not created for us. So therefore, a lot of our parents and grandparents were not educated on how to navigate the healthcare system. In fact, they were scared of it. There are plenty of reasons for that as well. I think, to me, the one thing that I think about when I think about, I guess, adherence, is patience and different strategies. I think providers need to be talking constantly about how can they be a better provider for a certain group of people. For example, for someone from a different racial ethnic background. And if we're talking about Black and Latino MSM, there should be way more cultural competency trainings going on how communities of color work, right? Latino communities, Black communities. I think it's really sad that the CDC never puts out data and statistics on Asian communities. It's like they don't even exist. That's also honestly pathetic. It's like they're out there, so why do we not have any data on them? It's complete invisibility as well. But there needs to be more cultural competency. God, why can I not talk right? around for providers on how to engage their patients. And it's not just, okay, I'm going to prescribe you a medication, see you in 30 days, because that's not necessarily how it's going to work for us.
Yeah. So I'm in thinking about that. And just wanting to unpack that a little more. I'm thinking about those young people who are undocumented and at high risk of HIV. I'm thinking about those young people who cannot afford the $50 copay and who may not know that, here's Gilead has this program to help them, right? Who may not know that there's pharmacies that can deliver meds straight to your house. Or that young person who's working 2 part-time jobs and doesn't have health insurance and doesn't qualify for Mass Health, because they make over a certain amount of money. Like, these are real issues that I'm finding people facing. And I think that, one, it's about creating that system for people highest at risk for HIV. And it's not just come, let me draw your blood, prick your finger, give you an HIV negative result and put you out. But it's like, okay, you're at risk for HIV. How can we get to you before HIV gets to you, right? How can we address the systemic things in your way from accessing prevention? How can we talk and address housing disparities? How can we talk and address underemployment? How can we address these multitude of different things in the highest risk populations? And that's something that I feel we have to focus on and we have to look at. And that's just what my recommendation is. I love what you said, Dwayne, around creating that care continuum for people who are HIV negative and having intensive case management for people who are negative. Because I do believe people who are HIV positive, we have to do that intensive case management. But I feel that we are not doing the work of saying to people, do you want to get Truvada as an HIV negative person by choice? Or do you want it to be among your treatment regimen?
Right.
And we have to get to people beforehand. And I think that's something that we definitely need to start to look at and focus more on.
Yeah, I mean, the focus in public health has always been reactive. So it's all, and especially when it comes to HIV/AIDS. I mean, and that made sense. We didn't, we weren't expecting HIV/AIDS to hit America in the early '80s, and so we created systems that were reactive. We created systems but now we are in a very historic place in the HIV epidemic where we can be proactive, and so we need to be starting to create more proactive systems where we are. So we're not when somebody gets infected with HIV, as a public health model, your first job is to make sure that they are not infecting others. Correct. And so you're doing everything you can. There's this case management to make sure they're not infecting others. But now that we are in a place where we can be proactive, we also need to be thinking about what you just said. How do we get HIV? How do we protect someone from HIV before they can even come in contact with it? And doing everything we can, not just saying telling them that you can do these certain things, but also providing those things and also making sure we're getting those things to the community.
Something else I think that we have to talk about too is as providers being among the problem, right? And I say that, and I'm going to talk about it in one sense. I found in the work that this work doesn't stop at 5 o'clock, right?
Right.
And for a lot of folks who want and need to get HIV testing and who want to be able to access PrEP or access prevention in different ways, they may not be free between 9 and 5. You know, and how is it, or they may need to receive services on a Saturday, you know, and how can we change the system that is working around the clients and working around the community and working around folks, right? I think that as a system, we work from a very reactive place than a proactive place, right? I also think that as a system, we work from a deficit place rather than a strength-based place. And I think that those are two changes that we have to make. Rather than saying, okay, let's do this, let me do this, and prick your finger, and et cetera, how can we say, okay, what are your strengths? How can I support you? How can we create a prevention strategy to be able to prevent you from becoming HIV positive, you know?
I think it's really important too to take into consideration that this healthcare system eventually a long time ago was created, a long time ago was created as an oppressive system, you know, and it wasn't,
very true.
Once again, it wasn't helping, wasn't for us. And I think it has continued to work that way where the people who were in the margins, right, continue to fall off and nobody cares, nobody notices, except for, you know, for the people who are oftentimes part of those communities and on the ground doing the work. But I think it's important to take into consideration that we're going to be doing a lot more hand-holding, and that is just what we have to do.
We have to.
You know, and I think, you know, it's like you said, right? Like, here's the information to, you know, Gilead copay, right? But I'm someone who's never dealt with health insurance at all. What are the chances I'm actually going to go ahead and do that?
Exactly.
There aren't many, right? And this whole idea that, like, we have to empower our people to do it on their own. Yes, it's great, right? But do we want to prevent them from becoming you know, from becoming positive? And if we do, and then empowering them after, can we take that little extra step, put in that little extra work, and do a little more now, and then working with them later? You know, and I think. Yeah, I just think it's like we have to stop working with this idea of like, oh, you know, people have to be self-sufficient and blah, 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 and all these things. Yes, we have to be self-sufficient, right? But some of us have not had I guess the training and haven't been given the tools to do that right away. And we need to take that into consideration as well.
So as we close up, I want to give everyone an opportunity to have some closing thoughts. Dwayne, do you want to start?
Yeah, it's. I think the main thing we have to. There has to be several pronged approaches. Like we have to. There's so much systemic oppression. We have to basically do a lot of systemic infiltration at many different levels in order to get to zero, as we keep talking about. You know, we can't keep just assuming that HIV 101 is kind of common knowledge. We even as we go into this age of PrEP and all these new things, we need to continue to realize that we need to be discussing this at a basic level in many communities. And so, yeah, we need a multi-pronged approach in order to get to zero, for sure.
I agree. Yeah, I mean, I agree 100% with all of that, and I just kind of want to add that, like, you know, we need to continue to remember that, you know, in an age of social movements like Black Lives Matter, like United immigrant movements and different immigrant movements, rather, we have to keep in mind that, you know, discrimination is happening within the healthcare system. People are only paying attention once we become a risk to them. So once it comes to stopping us from infecting them with anything, that's when people pay attention to us, right? But I think our health is important, and I think, you know, we have to start paying attention to that and teach people how to prevent, educate them around all these different things. And you're absolutely right. You know, assuming that HIV 101 is no longer necessary just because we're living in the age of PrEP is ridiculous, you know, because it's not the case. It's just not reality.
Yeah. So my final thoughts, like you said, Dwayne, I think we do have to take a multi-pronged approach. And I think that one is going to require for the community to hold us as providers and those of us as researchers, holding us responsible. I also think that what it's also going to take is it's going to take intensive case management. It's gonna have to talk about and deal with the real issues that people are facing in their everyday lives. And I think that we have to do that work. Also, we have to center access as equity, and we have to look and talk about racial justice and economic inequalities that people are facing that create these barriers. And I think that those things have to be centered, and it's not going to be an easy job, and it's not going to be done tomorrow, but it's important that we start to take those steps. I think that in many ways the establishment has failed us, and I think that it's time that we bring folks to the table that are outside of the establishment, who are from the community, who are going to be able to help us to develop solutions and do this work together. So yeah. Thank you guys so much.
Oh, thank you.
Thank you guys so much. Thank you guys for joining us. Until next time.